Welcome to the Society of Thoracic Surgeons General Thoracic Surgery Database monthly webinar. Today is Wednesday, February the 12th, and happy early Valentine's Day to all of you out there, or happy early Singles Awareness Day if you're like me. So happy early Singles Awareness Day or happy early Valentine's Day, whichever you celebrate. So I hope you guys have a great Valentine's Day on Friday. All right, let's go ahead and get started. On the call with me today from the STS side of things, we have myself and Emily Conrad, Banu Yatsi. We have Nancy Honeycutt, Ruth Riley, our GTSD clinical consultant. Jane Hahn is on today, as well as we also have Katie Lothar from our core group, and Paul Meehan and Sydney Clinton. So thanks everybody for joining me on the call today. Just super quick agenda, same old, nothing new. They'll just provide a few STS updates, and then we'll turn things over to Ruth for our educational updates, and then we'll wrap up the call with our Q&A. If you have questions, please be sure to put them into the Q&A. I think we'll turn the chat off here in just a second, but please put your questions into the Q&A. And if you do have questions, you're free to raise your hand and enable your microphone. We'll just unmute you, and you're welcome to ask your question. We'd love to hear your voices. So I'm sure you guys get tired of listening to me and Ruth talk all the time. So feel free to raise your hand. We'll unmute you, and we'd love to hear your voice and just ask your question if you prefer to do it that way. All right, so let's go ahead and hop into our STS updates. Just a reminder for the Spring 25 harvest is coming up soon. We're a little less than a month away from our harvest close. So that Spring 25 harvest close date again is March the 7th. That will include the reporting period of January 1, 2022 through December 31st of 2024. Following our Spring 25 harvest, we'll hop right into immediately our Fall 25 harvest. The Fall 25 harvest close date is scheduled for September the 5th, and that Fall 25 harvest will include the reporting period of July 1, 2022 through June 30th of 2025. With the harvest close coming up, I know last harvest in the fall, we held a GTSD office hours session. So Ruth and I thought it would be good to bring that back again for the Spring 25 harvest. So our GTSD office hours session is going to be held on Monday, March the 3rd at 2 p.m. Eastern, 1 p.m. Central. And if you weren't able to join us last harvest for our office hours, this is simply a 1-hour drop-in session. It will be open to all data managers. It's very informal. We won't have any slides. We won't have anything like that. Literally Ruth, myself, and Banu, Paul, our help desk staff, help desk team, will be available to answer any questions if you guys are having issues with Uploader, if you have any MPI related questions, if you have any questions related to harvesting your data, any last minute coding clinical questions, we will attempt to answer those as well. But so Ruth, Paul, myself, Banu, as possibly as other STS staff, Emily will be on as well. We'll be available to just answer any questions for you. We will send out a reminder email for this call on Friday, the Friday before the call. It'll be a Teams meeting just like it was last time. So we'll have all of the dial-in information. The meeting link will be in that communication on that Friday before the call. So again, just mark your calendars and look for that email. That email will go out to the primary data and file contacts as well as the backup contacts. So we look forward to our office hour session, and again, feel free to join us. All right, the next thing that I wanted to do was just give a brief GTSD reporting update. As you know, I'm sure many of you received the email just that was sent at the end of January. I believe it was the 24th or 25th. That official communication did come from the STS indicating that effective Spring 25, the GTSD reporting updates would include that the STS will be removing the STAR from the participant report and public reporting. Now, keep in mind that we are simply, STS will just simply remove the rating graph, the star rating graphic for both of the esophagectomy and lung resection composite measures. So I just did a snippet of the report, of the current report. So we will continue to use the 3 category analytic descriptions. So for example, in the spring 25, if this were your report would look just like this. It would say overall, and instead of showing the 3-star graphic, you would get better than expected in this column. For absence of mortality, a 2-star, instead of the 2-star display, you would get as expected. Absence of major complication, if this were a 1-star, instead of the 1-star visual, you would just get the words worse than expected. So again, that communication, that official communication was sent out to the entire GTSD database community, both surgeons as well as primary data and file contacts. So again, the surgeons are aware of this. This communication came directly from our STS president, Dr. Romano. So again, this will be effective with the spring 25 harvest. This will be for our participant reports as well as GTSD public reporting. Just to give you an idea of what the public reporting page would look like, again, we are simply just removing that star graphic. The words better than expected will be displayed. As expected will be displayed, again, just to give you some sort of visual of what our public reporting page will look like. And again, this is effective spring 25. The remaining of my STS updates, again, I don't have a lot of information to update today. That February training manual will be posted by today. It is with our marketing team, and if Grace gets that posted as soon as possible, it might get posted while we're on this call, I'll let you know. But for now, our January training manual is posted. And then this February training manual will be posted today, but just keep in mind that that FAQ summary document, you can go in and quickly look at those updates that were provided for December, January, and February. So again, all of that, the training manual is going to be available out on the website. If you have any report-related questions, please continue to email the help desk at stsdb_helpdesk@sts.org. And again, just a couple of reminders before you shoot that email off to the help desk. If it's a question regarding the report, just please, refer to the analysis overview. A lot of times those questions, or your questions, can be answered just by reviewing that analysis overview. If not, again, just shoot that question over to the help desk. Please, please, please include your participant ID. When you send your question, indicate the specific reporting time period, which harvest report you're referring to. Are you referring to fall 24? You return to spring 25, fall 23? Just please let us know which report you are specifically inquiring about. And also please include those screenshots. Screenshots are super helpful. It'll save time getting your question answered instead of going back and forth. But again, please include your participant ID, the reporting time period, and screenshots are helpful. All right. One last update from me before I turn things over to Ruth. AQO 2025. Again, AQO 2025 will be held in San Antonio, Texas. Our GTSD will be held San Antonio, Texas, October 2nd and 3rd. So it's 2 days this year. Our GTSD and CHSD sessions will be held concurrently. They will be held on Thursday, October the 2nd, and then we will have our ACSD session on Friday, October the 3rd. We will be at the Grand Hyatt San Antonio Riverwalk. So we look forward to having you all join us there. And also we will have, again this year, just as we did last year and in previous years, we'll have both the in-person and virtual option available. Cost information will be shared with you all as soon as possible. We don't have that available just yet. Our team is still working on how the pricing for AQO 2025. But again, we will share that as soon as it is available. And then also new this year, we do have an AQO session proposal. If you would like to propose a session for AQO, we would love to get your feedback. The deadline for the proposal is April the 18th. I'm going to pull the STS website over so you can see where to find the link to the session proposal. So The session proposal link can be found here on our AQO page, and you can get to this from the STS website, simply going to education, clicking on calendar of events, and then just scroll down to, I think it's the third or fourth row down here. You have advances in quality and outcomes 2025 data managers meeting, and this will bring you to our AQO page, and just scroll down, and here's our link to the session proposal. So again, we would love to get your feedback and get some ideas for sessions for 2025 to make sure that we are giving you the educational content that you all are wanting and needing. And again, we'll share that cost information as soon as it is available. Okay, I think that is all that I have from the STS side, and then we'll turn things over to Ruth.
Plan.
Mhm.
Okay, apologies in advance, everyone. I have a new puppy. If the squirrel runs by, you're gonna hear barking. So sorry. Okay, so first I wanted to start off with some reminders on important resources, and Leanne referenced these in her presentation, but just wanted to put them in a nice list. So first of all, the training manual, which gets updated monthly. Please don't skip the first few pages. I know it's tempting to just like search for the sequence that you're looking for. But the first couple of pages have some great information. There is actually a list of helpful resources at the very beginning. And then the second or third page, I think, tells you really how to use different types of sequence information. So known and unknown questions, known and not documented questions, values outside of an acceptable range, like how you should manage all of those different question types is listed in the first couple of pages of the training manual. And then don't forget that the neoadjuvant training manual is a separate document from the version 521.1 training manual. So when you're filling out your neoadjuvant REDCap forms, please reference the neoadjuvant training manual. We now have a new surgeon who is supporting questions that you all are submitting for the neoadjuvant training manual. Dr. Oh goodness, it's Dr. Broderick, right?
Yes.
That's doing that for us now. Yes. And so I think that's going to be great. Dr. Broderick has been highly involved in developing this, the REDCap and using that data. And we hope to have him soon present to all of you on the REDCap data and how it's being used. Next, don't forget about the analysis overview, which no, it's good, that Leanne referenced. It's in the IQVIA library. Super helpful tool, especially as you're reviewing your reports with your surgeons and like, how did A get to B? The analysis overview is critical. And then hopefully this link will work, but if you are not familiar with the STS website, this resources for data managers will take you right to that page and links you to essential forms, webinar slides, and recordings are all out there. And then of course you can get to the training manual through that link. If you want to go to the next slide, please. So now we're going to go through a couple of educational updates for this month. So sequences 1890 to 2000 have had some clarification added to them in order to help align with Commission on Cancer standards for capturing lymph node resection for lung cancer patients. So if your surgeon is reporting that a lymph node is sampled at a station, but ultimately the pathologist determines that there were no lymph nodes in the sample, so it's like fatty tissue or whatever they happen to grab, then you're going to code not sampled for that relevant station, unless, of course, there was another lymph node sampled from the same station that was either benign or malignant. I think previously some data managers were coding benign when in fact there were truly just no lymph nodes. So on to go forward, those are captured as not sampled. I'm going to go to the next slide. We have gotten a lot of questions about how to interpret final pathology reports for lung resections. So actually that's going to be the focus of our March webinar is really how to interpret your pathology report, specifically focus on nodal stations and nodal resections, nodal staging by your pathologist. But happy to review any aspects of pathology reports in March. If you have a pathology report that you would like reviewed or that you think would be helpful for others to have reviewed, please send it to me, and I put my email address in there, and I'll include them in the March webinar. Unless we get hundreds and hundreds of examples, I will include every single one of them. Okay, next slide, please. So now we're going to talk about blowholes for a few slides. So you can see in the CT image on the left-hand side of your screen, all of that, there's like two little blue arrows pointing to these dark spaces outside of the patient's rib cage, which represents air. So sometimes patients will have what's called subcutaneous emphysema, which is a bunch of air trapped between their skin and their chest wall. This can happen for various reasons, but does happen occasionally after thoracic surgery. And so then what they will do sometimes is create a blowhole, which is what's diagrammed here on the right-hand side, where you can see that they make an incision in picture A in the patient's skin, and then air will sort of start bubbling out of that incision that they make, which you can see in picture B. And then in picture C, they use some material to sort of create a seal. And then in picture D, you can see that they've hooked it up to some sort of suction. So commonly like a wound vac or something like that, that's external to the patient's body, but just sort of sucks the air out of that space, which is really important because if you want to go to the next slide, you can see that for patients who have significant subacute emphysema, there can be a lot of potential risk for these patients. So if enough air accumulates between the patient's skin and other structures, they can have, airway challenges. Their eyes quite often will swell shut, et cetera, et cetera. You can see that this patient pre-intervention in that picture labeled A and then post in picture C looks like a completely different person. If you're going to go to the next slide. So I get a lot of questions about blowholes because you feel like they should be captured. They must be captured somewhere, like it's helpful for the patient or it's, significant that a patient, obviously, like if you walked into the room and that's your person and they look like that, you're like, oh my gosh, it has to be captured. But truly, they're not necessarily captured unless the patient meets one of the definitions for one of the other sequences of the training manual associated with like sort of the extra air concepts. So you would capture air leak greater than 5 days only if the patient meets the specific criteria for air leak greater than 5 days. And there's a lot of FAQs for that one, so I didn't copy paste all of it here, but look in the training manual. And if they meet the definition for air leak greater than 5 days, great, capture it, but don't capture that just because your patient had a blowhole. Potentially, you could also capture pneumothorax requiring chest tube, but only if your patient has a new chest tube inserted, and a blowhole isn't the same as a chest tube being inserted. A chest tube might also be placed, but a blowhole by definition isn't necessarily equivalent to a chest tube. So you would only capture that one, the sequence 3800, if that definition is met. I'm going to go to the next slide. So this sort of ties back to this concept, things that happen to patients after big surgeries, and lung surgery and esophagus surgery both of them are huge surgeries. Just because something unexpected happens postoperatively doesn't mean that it has to be captured. Some really big things can happen postoperatively that significantly impact your patient's length of stay. Again, we intentionally do not capture every single one of those. You're going to want to remember to always follow the training manual and capture what's outlined there. If you're not sure if something should be captured, feel free to send an FAQ. And then finally, my last educational slide. Patients are, so talking about DVT, which is one of the post-op events, acute DVT, sequence 3890. Many patients these days are on chronic anticoagulation prior to either lung or esophageal surgery or any of the other procedures that we collect for a history of AFib or a history of a previous DVT or. There's a million reasons that patients could be on anticoagulants. This complicates the capture of sequence 3890 sometimes because you really have to dig into the record a little bit more to determine if your patient has a new acute post-op DVT and has treatment for that DVT, because you're only going to code yes to 3890 if there's a change to the management of their chronic medication. A change can be either a different medication or a change to a dosage of the medication that they were on previously, or a medication that they plan to hold for, say, 2 weeks post-operatively that they have to restart immediately because the patient has an acute DVT. So for example, if you had a patient that was on Coumadin preoperatively for a history of AFib, had been on Coumadin for 15 years, postoperatively gets an acute DVT and they put the patient on Lovenox, that would be captured because you have an acute DVT and you have treatment. However, if that same patient was on Coumadin pre-op, has an acute DVT, the Coumadin is held as long as they were planning to hold it and they just put the patient back on the same dosage of medication, then that patient would not be captured in sequence 3890. So it's a little more complicated. You'll really have to dig into your record. And if you get stuck, as always, send an FAQ, but please send your notes. We'll definitely need notes on that one. And I think that is the end of my slides.
Yes. Yep. Thank you so much, Ruth. So we do have some questions coming in, and I want to go ahead and tackle those. Let's see here. So our first question, Denise only sees the November 24 training manual. Denise, if you have it bookmarked or you may need to clear your cache. Right now, the website has the January training manual posted. So like I said, you may just need to refresh or clear your cache and then re-access the page. But it currently has the January training manual posted. Our next question, will we get feedback on the REDCap forms so we know if we completed them correctly? Would you reach out to us if there was need for clarification? So the way that the REDCap works, honestly, we do not see any of that data. The REDCap data is entered into the REDCap form, and then I don't know, Paul, I don't know if you know where it's housed, but it's housed somewhere separately into a separate database over in research in our STS database analytics and research land. And all the data is collected and captured there. Our surgeon leaders will ask for the data, and then they will look at the data and analyze it. So once they start reviewing the data, there may be some additional follow-up questions. I'm not sure, but we do not look at the forms when they come in to see if they are answered appropriately. I don't ever see them. So once the surgeons can, ask for the download and look at the data and start to analyze it, there may be additional questions or something that we may come back to you guys with, but not as those forms are getting submitted. Jody, when can we stop collecting the neoadjuvant information? We have not gotten a date from our surgeon leadership on when they would like to cease that neoadjuvant collection. Our goal, what we'll probably do is we're in the middle of doing an upgrade, a minor upgrade for GTSD at the moment. I have a feeling with our next major upgrade, a lot of this neoadjuvant information may get added to the data collection form. Some of it may get added with this minor update that we're doing. So we need to reassess and talk to our surgeon leaders and the task force. So on what their plans are in terms of how long they want to continue to collect this data. Hopefully, like Ruth said, we would like to have Dr. Broderick come back and talk to us about the data that has been submitted thus far, what they plan to do with it, what's the plan in the future, how long they want to collect it. So hopefully we'll have him come back again and find out more information and give us some ideas on what the timeline's looking like. So until then, we continue to collect until further notice. And Ruth, this question from Amanda. So we are saying to capture blowhole. Do we capture blowholes or don't? Just verify. Just because they have them, we don't always capture them. Yes, we don't capture them. Yes, we said, but they aren't always required for intervention. Sub-Q AR. If a patient requires blowhole and suction setup, we capture. Yes.
Oh, no, blowholes in and of themselves are not captured. Blowholes signify that the patient has some type of post-operative air event. So you're going to want to make sure that you don't need to capture pneumothorax requiring chest tube or air leak greater than 5 days. But just because your patient has a blowhole does not mean you need to capture it. anything, because blowholes in and of themselves are not a captured post-op event.
All right, and
No problem, Ida. Thank you.
yeah, good question. Okay, she said, sorry, that was confusing, and it's okay. Just want to make sure we get it answered for you. I saw there was another question that Banu had answered regarding the Harvest composite quality rating summary. So that even though we will continue to post the Harvest composite quality rating summaries, they are held in the library. I don't know if your library, when it opens, if it's collapsed or not, but the Harvest Composite Quality Rating Summary is under this tab, and the fall 24 one is down here. But yes, those will continue to be posted after each harvest. All right, and next, I think we have another question. The red cap data is still optional. Yes, so the red cap data is optional, it's not required. So yes, it is optional.
But I'm gonna put in a plug for it because it's really, really important data.
Yes.
And it's like the surgeons are so excited about it. And I know that you don't get to like be present for their excitement, but the task force is enamored with this data. So thank you for collecting it. Please collect it if you can. It's really helpful to our patient population.
Yeah, and honestly, Dr. Broderick, I saw him at the annual meeting in Los Angeles, and he always asks about the red cap data, and we had just gotten a download from the vendors, for those vendors that collect the red cap data and their software. We had just gotten a download from the vendors, and I gave Dr. Broderick the update with the number of cases, and his eyes just like lit up. He was so excited. So this, like Bruce said, this data is very important. Yeah, if you could continue to collect that red cap data, you would. It's very exciting, and I'm really, really anxious to see what the surgeons are going to do with it. So. Our next question, is it mandatory to answer the 90-day follow-up for thymectomies and the 1-year follow-up for paraesophageal hernia repairs? Do you want to take that one, Ruth?
I mean, there aren't required fields anymore.
Okay.
And there's no analysis or risk adjustment that occur for thymectomy and paraesophageal hernia repair. I will say that as we've talked with surgeons for the next upgrade, they feel like keeping additional follow-up dates for paraesophageal hernia and thymectomy is clinically very important to understanding the outcomes for these patients. So I can't recall offhand if it will be maintained at like the 90-year 1-day interval, but it will be maintained in some way, shape, or form, just because it's important for understanding truly the course that these patients have had and how we can provide better care to the patient population.
Yeah, I think that's, from our last call, that's what they wanted to one of the things they wanted to discuss with the broader group of leaders, is the surgeon leaders, is, do we do the 30-day, the 90-day? Do we do just 90 days? So some sort of follow-up will continue. It's just, I think we need to narrow down, do we do 30-day, 90-day, 1 year? Well, so that's something to be determined. For thoracoscopy with lobectomy, should we be answering sequence 32674? Thoracoscopy with mediastinal and was it regional lymphadenectomy, or is that captured in the lymph node sampling section?
32674 accidentally was not deleted for this version. It'll be deleted in the next version. You're not required to enter it. However, I understand why a lot of people continue to enter it, just because it makes things feel nice and tidy the way that they used to be before, but you don't have to. Because that data is captured in lymph node sampling, as you pointed out in your question.
Okay. All right. All right, while we're waiting for additional questions, just to mark your calendars for our next upcoming monthly webinars. Again, our next monthly webinar is March 12th at 2:30 Eastern, and the April webinar is April 9th at 2:30 Eastern. And I I don't see any additional questions. Is
Carissa
there,
has
yeah, go ahead.
do you have to unmute her?
Oh, somebody has their hand raised. Oh,
Yeah.
Marissa, yeah. Sorry, I didn't see that. Thank you, Ruth. Marissa, I think we've unmuted you. I don't know. It looks like you're still unmuted. Oh, you just lowered your hand. She didn't want to talk to us, Ruth. It's okay. We won't take it personally. Okay.
Hi, Leah. Since we have the time, I just want to remind everyone that, as you know, the GTSD August close is approaching. So please do not wait till the last week or the day to upload your files. It gets really busy as we near harvest close, and when you need your password reset because you have not logged into your account for a while or need help with uploading, we might not be able to respond back as fast as we'd like to because of the increased activity on our end. So please log in a week before to confirm your credentials work and try to upload your records as soon as possible. I'd recommend not waiting till the last minute. Thank you.
Yeah, thanks, Pano. So a question from Denise. Are you going to be doing the data manager training sessions for GTSD like they're having for ACSD starting on February 25th? So actually, Ruth and I just talked about this yesterday. So I told Ruth, what Nancy and Melinda are doing for ACSD. So instead of doing for ACSD, instead of doing, for those of you that aren't aware, instead of doing a new data manager training webinar, or one new data manager training webinar, ACSD is breaking it down into 7 different sessions, which I think is a phenomenal idea, because there's a lot of information that needs to be covered, and trying to cover everything in one session is it's a lot of information, and it's a lot of talking, and it's 2 hours of that it gets a little little boring at times, not gonna lie. But it's just really a lot of information, and I think we are probably more than likely, I think, talked about, I think it's a great idea to follow a similar format for GTSD, and also looking at doing something similar for CHSD. CHSD is a little different beast in all of its own, but yes, Denise, I do very much see us doing the same type of data manager training for GTSD like we're doing for ACSD. So more information to come, yeah, on that data manager training. Ruth and I have to figure out the dates and all of that. So did you want to add something, Ruth?
The only thing I was going to say, the other thing we're looking at is if there's an opportunity to consolidate and have any shared content for both ACSD and GTSD for things that are the same. For obviously training manuals specific items, that does not make any sense, but on like where to find useful forms, maybe that does make sense, or other things like that. So Leanne and I are going to explore it some more, and
Yeah.
date soon.
Yep. So next question from Brenda. Patient had an axillary node biopsy during pre-op EBIS. Where is this captured?
Probably nowhere, I guess. Captured in what sense would be my question. If there's a specific sequence that you're asking about, that would be helpful. My guess is they were trying to rule out metastatic disease, and if it was negative, then the patient would be clinically staged as not having metastatic disease, is where that would essentially be captured.
Mm-hmm.
I mean, I don't think my guess is that this is like a separate procedure performed maybe by your surgeon or something like that. So I need a little more info, Brenda. If you want to send it in as an FAQ, I'm happy to answer it today for you.
My next question from Michelle, just to clarify, as of right now, do we need documented evidence that we attempted to contact a patient for 30-day follow-up and post-op complications?
Yes, unless it's documented in a note in your medical record somewhere that the patient was alive at 30 days and had no post-op complications in 30 days. You can't just see that there's nothing in the chart for 30 days and assume that your patient is both alive and had no post-op complications.
Perfect. We don't, no assuming. Next from Sandra, can you please answer this again? Her computer went out. Is it mandatory to answer the 90-day follow-up for thymectomies and then 1 year for paraesophageal hernia?
So there are no required fields anymore. And there's no analysis or risk adjustment for either one of those procedure types. So while it is not mandatory, it is extremely helpful data to collect because it's extremely meaningful to the utilization of all of the rest of the data that you're submitting.
Yep. All right, should we be capturing history of non-obstructive CAD, or does CAD need to be obstructive, have blockage in arteries?
Hmm. Hang on, let me pull up 6. I think that's 610. One moment.
Hold on. 610.
Yeah, I think so.
Okay, I've got it. Here we go. I don't know. It's
Just coronary artery. Okay.
This is Katie. It just says, it does say that you just need documentation of CAD in the H&P by the provider.
okay.
It doesn't mention that it has to be obstructive.
Okay. Oh, that's vascular. Okay. Sorry, I was in the wrong field.
That's
Okay.
right. It's on page 28.
Okay.
They gave you the wrong one.
Oh, yeah, that's all right. I was looking, I was like, wait, that's vascular. Okay. What page am I on? Oh my God. Okay. Thanks, Katie. There we go. There it is. Okay. Whitney, in reference to reading the beginning of the TM with respects to no and unknown captures, when you have follow-up notes, but no one addresses if the patient is still on home oxygen at 30-day post-op, do you feel it most appropriate to code unknown?
Well, I'm reading no and unknown. And it says specifically, if there is a history of physical or consultation and the values are not addressed, code no. For example, if there is no mention of a history of cancer, then code no. Unknown should be coded in the circumstance where no clinical documentation exists and the patient cannot give a history, and in certain situations when you know the patient has a history, but you don't know if it's within 5 years. I would say that unknown is the appropriate response, given that feedback, because you know that the patient went home on O2. If they don't specifically address it in your note, then you don't really, what you're missing is the time frame, which would lend me to believe that unknown is the right answer, but.
Thank you. And then someone, and we also wanted to know if you could repeat the follow-up post-op event answer. So if you needed to have documentation, I think that's the question.
Oh, yeah, so you cannot assume that if there is no note in your chart that the patient had no post-operative events.
Right.
So if your patient had surgery and then just disappears, you can't say that the patient had no complications within 30 days. You really have no idea.
Okie dokie. Anything else regarding, we don't have any other questions, anything from help desk or public reporting side or AQO? Anything that I may have missed? Anything you wanted to raise? Going once?
I have nothing here.
Oh, Michelle has her hand raised. Oh, hold on, Michelle. I'm trying to unmute you. I don't know if yeah.
Can you hear me?
Yes, ma'am.
Hi, thank you. I have
Oh.
a quick question. If a doctor documents in the OR note that they're doing the procedure for both diagnostic and therapeutic purposes. How do we code that? I don't know how we're supposed to code that.
Most often you're gonna code that as therapeutic, thinking about lung resections specifically, I guess. So like if your patient has a lung nodule that was either not biopsied preoperatively or was biopsied and the pathology didn't return an answer, the surgeon will sometimes take the patient to the OR and then wedge out the lung nodule and then find out, okay, yes, this is cancer and I'm going to do this anatomic resection, or yes, this is cancer, but it's a very early stage and my wedge resection was sufficient. And so the patient requires no further resection. And this is also therapeutic. So your primary procedure is going to be the therapeutic procedure, whatever that is, the lobe or the wedge. And then your secondary procedure can be the diagnostic procedure followed by the anatomic resection, or if there was no further resection, you just have a therapeutic wedge at the end of the day.
Perfect, thank you.
To that, Katie, that I missed?
No, I don't think so.
Awesome, thanks, guys. A question from, I think this is Dawn. For readmission, patient has a 30-day follow-up visit. They don't mention readmissions. Is it true you can't assume there is no readmission? You would need a call to the patient or physician.
I mean, if your surgeon is putting in their note something like, the patient has done well with no post-operative events, et cetera, like to me, that is documentation that there is no readmission, right? Like the patient has been doing well and there's no post-operative events. I guess I can't, you can send me a specific example of your notes and I can comment, but like I can't imagine a note where a patient was seen by a surgeon 30 days afterwards and there's like no comment on how they've been doing for the last 30 days. Now, ideally, do they have a template that says readmission and there's like a yes, no, yes, but do most notes look like that? No, probably not, but maybe you can work with them on like cueing you a little bit better if they aren't doing that.
Yeah, Dawn said sometimes it's a follow-up with oncology. Surgeon sees it 2 weeks.
Yeah, again, I mean, there needs to be some documentation in the note about how the patient has been doing for that missing 2 weeks.
Amanda says we have been documenting unknown for auditing purposes since there's not documentation otherwise, but she doesn't know if that is right.
If you don't have documentation on whether your patient is admitted or, I'm sorry, has been readmitted or is alive, then unknown is correct.
Yeah. Correct.
But to add to that, this is Katie, if you then get audited and they look and then there is documentation later, like let's say 2-3 months later or something like that, then you will get a mismatch if you leave it as unknown. So I think you should, before you submit for harvest, you need to go back, you need to flag all your unknowns and double check all of those cases and do your best to answer yes or no.
That's a good point. Thanks, Katie. What if our system has care everywhere that would alert us if there was a hospitalization? Would that be acceptable?
No, because Care Everywhere only covers about 50%-ish of major health systems in the United States.
Yeah. And Amanda says, thank you. All right, next somebody, I think Mary, REIS 32. I don't know if I can't, they thank you.
Hi.
Go.
When you were talking earlier about primary and secondary procedures, you do want us to include all of the procedures in the initial part, and then at the bottom, you can add that there was a secondary procedure, correct? But you also would include everything where you're documenting the primary procedure. Is that correct?
You can only have one primary procedure. You're gonna include all of your procedures, then you designate
that's-
one as a primary, yeah.
That's what I meant. Okay.
Yeah.
Thank you.
I mean,
Just
the only
wanted to-
exception to that is that weird thing with the lymph node resection for lungs, because they got rid of the lymph node resection for open resections and we accidentally left it in for the VATS, and we'll clean it up, but and sometimes procedures are like so minor, they roll into something else. Like, I think we've talked about like pneumopexy and gastropexy. Like, I don't think there's even CPT codes for those. They just kind of get lost in the ether.
Right, but do you, if you can include a procedure under other minor and
Yeah.
then document is that optional or is it required?
You should list all of your procedures. So yeah, if there's a CPT code for something, then by all means, drop it in, please.
Gotcha. Okay, thank you.
So our next question, if you have 2% of unknown, doesn't that kick out the data? So the 2% missingness threshold is for the variables of mortality, discharge status, and 30-day status, mortality, 30-day status. So the 2% missingness threshold unknowns, it applies to mortality 30-day status and mortality discharge status. So I hope that helps. For the 30 days follow-up, if patient does not return to the hospital for insurance reasons, we called to find out if they have been admitted. Should we code no if we speak to the patient and he has not been admitted?
That's perfect. You're just gonna want to keep a log of that follow-up and you'll be all set. And give that to the auditor and you'll be fine in the case of audit. It's a great process.
Yeah. Awesome. Thank you. Yeah. All right. Any other questions? We've got about 10 minutes. If you do have a question that you think of afterwards, please feel free to just submit that. Sorry, my kid was leaving and he had to slam the door. Apologize for that. So if you do have any questions, please feel free to submit those to the FAQ and Ruth can get those answered for you. And not seeing any additional questions. And again, just a reminder, if you have any questions regarding your harvest, your upload, or any questions regarding your data quality report that you get back, your missing variable report, anything like that, please just submit those to the help desk. And again, the help desk can be reached at stsdb_helpdesk@sts.org. And then, of course, if you have any questions for me, you can just reach me here. Email is always best. All right. I'm not seeing any additional questions come in. So I guess we can go ahead and wrap up today's webinar. Just real quick, thank you again for everyone for joining today. Please be sure to fill out that session proposal form for AQO. Again, we'd love to get your ideas and make sure that we have the presentations and sessions that you all are wanting and needing. So please fill out that session proposal form. And I guess with that, I hope you guys have a great rest of your week. And again, happy Valentine's Day to all of those out there, and happy Singles and Awareness Day to all of us single people. So thanks everyone. I hope you guys have a great rest of the week, and we will meet you next month on March the 12th at 2:30 Eastern. Thanks everybody for joining today. Hope you have a great rest of your week.